I mean, this could be a huge benefit for patients that we, with the 2017 McDonald criteria, were very careful of starting treatment in, or just then didn't, but did the watch and wait procedure. And if we now treat them early, then disease progression in terms of new lesions or in terms of new symptoms, new relapses can hopefully be prevented. And there's also another issue in, like it's of course dependent on the location, on the nation. But in Germany we have an insurance system that gives us the opportunity to treat patients based on their diagnosis. And if we label them with a certain diagnosis, then the treatment is fully financially compensated by the insurance. But the problem is, if we cannot establish the diagnosis based on certain criteria, but we are quite sure that it might be this disease, we don't have, we cannot treat them even if we think it would be beneficial in these patients. And that's why we are very dependent on specific criteria, and also on criteria that we can apply to these patients that were like in the middle of, did I have autoimmune encephalitis, did I have MS, and they went to the neurologist, and the neurologist said, yeah, we don't know your diagnosis yet, it's maybe not MS, it's maybe not autoimmune encephalitis anymore, and they couldn't get any treatment, or it was very hard for them to get treatment, and we hope that this will eventually make it more easier to establish the diagnosis that then eventually will bring the therapy to the patient and will be fully recompensated by the insurances. So the key message of our findings, I mean, it was a nationwide cohort. We looked at a lot of NMDA receptor encephalitis patients, and we found a proportion of patients that had multiple sclerosis lesions, or that had T2 lesions in the brain, and that weren't treated and weren't even considered to be overlaps until we looked into them deeper. And I think the main thing, or the main message, is to carefully look at the encephalitis patients even after they've been treated for their episode, for their acute attack, and to regularly follow them up, maybe also with an MRI after 1 or 2 years, just to check whether there's any other neuroimmunological disease underlying this, because we also know reports from NMOSD or MOGAD being also overlapping NMDA receptor encephalitis. So just think about it and maybe just carefully look for these patients to not oversee anything that could help the patient to get a better outcome. And yeah, the question was whether there's something that I took with me. So I think I'm very excited for the eventual paper that will come out. But I think there are a lot of patients that we see in our outpatient clinics, not only autoimmune encephalitis, also other patients that come to us and that might have a multiple sclerosis diagnosis, but that do not fulfill the criteria, where therapy is prevented from them. And hopefully with the new diagnostic criteria we can provide them with the therapy they need. And hopefully this will make it easier now. I mean, it also looked a little bit complicated, so I think we have to look into it deeper when the paper comes out, but we're very excited. Maybe this is the opportunity now to help these patients that often come to us and then they're standing between two chairs and nobody really knows, can we treat, can we not treat, and hopefully this will change.
Anything else?
Thank you very much for having me.